Good morning, everyone. What else a pediatrician working in an emergency department choose for a new topic of interest in this constantly changing and really unpredictable era, which has a huge impact for children's everyday lives, meaning mentally, both physically. So we started to investigate the characterization of novel infections and child-friendly approaches. My mission is to give comfort for children in line with our title, with the fact of safety being natural in the long term for our patients, with utilizing evidence-based therapies in a child-friendly method. As you can see, we started several projects since the March of 2021, mainly investigating the long-term effects of COVID-19, and those started to investigate different methods for influenza immunization. Our first project was published in December. It was the primary assessment of children with long COVID. As when we started our project, it was a really new entity without no clear guidance, so we needed to start to establish a registry to learn a lot about this new disease and to start investigating their symptoms with doing a diagnosis of exclusion. So our main question was, what are the main clinical findings of multidisciplinary clinical assessment? And we evaluated the first results of our 89 cases of long COVID with confirmed COVID-19. They were mostly school-aged children, and we asked them about 50 different symptoms, and they reported an average of 12 symptoms per children for a duration of more than 4.5 months when they came to our clinic. We also evaluated their quality of life changes compared to before COVID, and you can see that most of them experienced an at least mild impairment in their quality of life, with a quarter of them having an at least moderate or severe changes, being mostly affected by their emotional life, going to school or walking a long distance or standing for a longer amount of time. To being able to evaluate the symptom-related medical findings, we created 10 different organ categories for these 50 symptoms. And we found that the pulmonary symptoms were the more frequent ones, with matching positive medical findings. As you can see, we performed a lot of medical tests, more than 400 ones during this diagnosis of exclusion, but the rate of positive findings were only 18% in our cohort. But surprisingly, we found also 7% of autoimmune thyroiditis confirmed by also ultrasound in our cohort. So with controlled studies, we really need to decrease the amount of performed tests for these children. So we need evidence-based guidelines, and we support thyroid screening remaining in future guidelines. As our registry and the number of patients increased, we really needed to switch to a more professional platform. So we created a RedCap platform for our follow-up visits and data collection. And at last, the third project of ours was comparing the different types of influenza vaccines in children. As you can see, in the past decade, deaths and hospitalization rates in the US didn't really change with the availability of really available influenza vaccines. And if we want to change it, there are assumptions that with the vaccination of more than 80% of children, we can decrease this burden not only in children, but by 80% in the most vulnerable elderly. But the problem is that vaccinations against influenza are not obligatory. So it's really, there is a factor of pain which can really decrease vaccination rates. And there are no particular types of influenza vaccines now which are more favored by professionals for children. So we wanted to investigate whether to choose the pain-free nasal vaccine or the inactivated intramuscular painful vaccine for children based on its efficacy, safety, and cost. We only used randomized control trials, and our main outcome of interest was confirmed influenza cases in children and young adults, with the hypothesis of if the nasal vaccine proved to be at least non-inferior, then it should be preferred for vaccination. After our systematic search and selection, we had 24 eligible articles for our meta-analysis. And our main results of laboratory confirmed influenza said that the nasal vaccine proved to be significantly better in reducing the chances of catching influenza after vaccination with a moderate level of evidence. But there are lots of influencing factors of efficacy. We investigated them, and we can say that with high level of evidence, the nasal vaccine proved to be significantly better in children younger than 5 years of age, in studies performed in more than 100 centers, and in children with respiratory diseases. Also, we performed the same analysis for studies performed for only 1 semester's data, and there were no significant difference between the 2 techniques. There is an additional factor for decision making, which is safety, and we evaluated serious adverse events, and there were no significant difference for related serious adverse events, no significant difference for adverse events or either hospitalization. But to help even more, we evaluated other components of safety, and the only one with significantly more events after immunization was runny nose after the nasal vaccine. But we wanted to investigate it more, so with a subgroup analysis on children with respiratory diseases resulted in a significant factor in the runny nose being significantly more present after the nasal vaccine. Without them, there were no significant difference. So we encourage professionals and children and families to use the nasal vaccine, which is really good for them, and also establishing child-focused national vaccination strategies. Also, there are lots of different components of vaccine efficacy and safety, so we should investigate them. And as you can see, our first project was published in December. Our second project about the nasal influenza vaccine is under review in a D1 journal. And we have also 2 other ongoing projects about our registry analysis. The first is about further evaluating this high rate of thyroid abnormalities and also smell and taste disturbances, which are the most objective factors of long COVID. And our thyroid dysfunction paper will be submitted in January, and the smell and taste project is planned to be submitted in September. Thank you for your attention, and research means that you don't know, but you are willing to find out. Thank you for your attention.
Why is the nasal better than the intramuscular? What are the? What are the explanation, the clinical explanation? What is the mechanism behind?
There are lots of different thoughts. Mainly, vaccine efficacy can be determined by your previous immunization history. And it's like a natural infection. So it not just affects on T cells, but it also creates a more broader spectrum of an immune response. And also, children didn't really have a history of being immunized, so this won't be a problem of conflicting immunizations.
Does your kid already have the influenza vaccination? If yes, what type?
My kid?
Your kid, yes.
Yes, she had.
And nasal or the regular one?
The nasal one, I tried it. I was quite afraid before administering it. But yes, we did it and there were no reactions, nothing happened after. And for children under the age of 9 who didn't really get any vaccination before needs a second turn, so it will be tomorrow or today, so yes, we will do it.
Does she like it? I mean,
yes, I was like, I got an intramuscular one and she watched it because my husband administered it. And I tried to be, yes, I'm okay. And she was really glad that, and she's 3 years old, that she also got it, but it was not painful. And we also kept not the syringe, but this administrative thing, and she showed it to other people that it was an injection, but it was not painful. So yes, thank you.
Thank you for this real-world data.
Yeah.
Were the children asked if they would prefer the nasal vaccine or the intramuscular, or the parents? Like, how was the reception? Did all of them say that nasal is less intolerable than the injection?
In these researches?
Or in your own experience?
It was not asked because they were randomized control trials, so they were just asked to be in one group. They could reject it, but they did not. And actually, we don't really have a huge experience because it just came out in Hungary last year. So lots of people doesn't really know about the existence of the nasal vaccine. So now we don't have a huge experience on acceptance.
Thank you.
Does a kind of a survey exist about this issue, what András asked? So maybe which is preferable for kids and parents, and just...
Yes, there are international surveys investigating this, mostly in America, but it's quite different because immunization is really different, and they started to use these school-based vaccination camps where they could choose which vaccine they want to administer. And the results of those, what I found, but not systematically, said that they would prefer the nasal vaccine, but there is borderline afraidness of this vaccine being live. So they are a bit afraid, but the nasal form is like, it seems to be like more preferable, being less painful.